Welcome to All in All. This deep dive is specifically for you, the dialysis RNs and techs looking to deepen your clinical knowledge, especially as you prepare for that registered nurse role in dialysis.
Yeah, we're focusing today on vascular access,
Yeah.
specifically arteriovenous fistulae and grafts, and that really crucial skill,
Yeah.
cannulation.
Right. We've taken a stack of information, the latest stuff, and we're breaking it down. We want to get beyond just the basics you already know.
Exactly. Moving into a more detailed, kind of in-depth understanding. Think of it like a guided tour through the must-know details.
Okay, let's unpack this then. The sources we looked at cover, well, pretty much everything. The different access types, how you assess them before you even think about a needle.
The various needling techniques, what can go wrong, the complications, and, importantly, how you bring the patient into the loop.
It's a really core skill in dialysis nursing, and what's interesting is that some sources highlight areas where practice is still, well, maybe not as evidence-based as you'd expect.
That's definitely something we'll touch on, but maybe let's start with the basics, the foundation, the different access types for hemodialysis.
Good idea. So the main three.
Yeah, you've got your arteriovenous fistula, the AVF, then the arteriovenous graft, or AVG, and of course the central venous catheter, the CVC.
And the AVF, that native fistula where they connect an artery and a vein directly, that's generally the top choice, right? When it's possible.
Absolutely. The sources are really strong on this. The native AVF is preferred, and the reasons are pretty clear. They tend to last longer, and they have significantly lower rates of serious problems like infections or clotting compared to grafts or catheters.
So if a patient's a candidate, you're aiming for that AVF.
Precisely. Now, sometimes, creating an AVF just isn't feasible. Maybe the patient's own vessels aren't great or they've had previous ones fail.
Okay.
That's when the AVG, the arteriovenous graft, comes in. It uses a synthetic tube to make that connection. It's definitely more prone to issues than a fistula.
Right.
But generally still considered better than having a long-term catheter.
And the CBC, the catheter, that's more for temporary use or maybe a bridge while waiting for something else. Or if other options just aren't working out.
Exactly. CVCs are absolutely vital for immediate access, sometimes temporary, and they play a big role in managing complex situations. But yeah, they come with the highest risk, especially for infection.
So understanding that hierarchy, AVF first, then AVG, then CVC as needed and why, that's fundamental.
Totally. It shapes how you approach care for that patient.
Okay, so you know the access type. The next critical step before any needles get involved is that pre-needling check every single time.
Non-negotiable, every treatment. And it's really the responsibility of the person doing the needling, the needler.
And the classic way to approach this is, look, listen, feel.
That's it, the fundamentals.
Let's break that down. What are you looking for?
So you're doing a really careful visual check, look right at the skin over the access, check out the old needling sites, see how the whole arm or limb looks overall.
Any specific red flags?
Oh, yeah. You're scanning for any new bulges like aneurysms or existing ones look bigger or different. You're looking for skin problems, thinning, shiny skin, any breaks, rashes, swelling, and of course, signs of infection. Redness, warmth, any oozing. Catching those early is just critical.
Then you move to listening with a stethoscope.
Yep. You listen to the bruit, put your stethoscope along the whole length of the access. That whooshing sound, the bruit, tells you a lot about the blood flow. If it changes, that could be a sign of trouble, maybe stenosis developing.
Okay, and the hands-on part.
Yeah.
Feeling. What are you palpating?
You're feeling for the thrill, that vibration, again, along the entire access. And pay special attention to the anastomosis, where it's all joined together. Palpation gives you so much information.
Like what specifically?
Well, you can feel which way the vessel runs, how much usable length you actually have for needling, roughly how wide it is, how deep it sits under the skin, and maybe most importantly, areas you need to avoid, like hard spots, maybe scarring or stenosis or dips where it gets tricky or other vessels getting in the way.
So this daily, look, listen, feel is your frontline defense against acute problems, a growing aneurysm, skin breaking down, infection starting before you stick a needle in.
Absolutely. And if you find something concerning, you have to escalate it immediately. You don't just ignore it and needle anyway.
And ignoring it could lead to pretty bad outcomes, like rupture.
Yeah, a rupture and hemorrhage is a real risk, especially with aneurysms under thin skin. It's also worth mentioning, besides this daily check, the sources talk about doing more in-depth assessments less often, maybe monthly or every few months.
Using specific tools sometimes.
Right, like the XSS tool mentioned in some sources. These can help pick up more subtle signs of problems brewing, like stenosis, even before they're obvious day-to-day. Combining your daily hands-on check with those structured assessments is probably the best approach.
Okay, assessment done. Access looks okay. Now, the needling itself, the sources talk about 3 main techniques.
Correct. You've got rope ladder, buttonhole, and area puncture.
And the general advice is?
Stick with rope ladder or buttonhole. Actively avoid area puncture.
Area puncture, that's just sticking in the same small zone repeatedly.
Exactly. And the sources are really clear. Never use area puncture on a graft, an AVG.
Why not on a graft?
Because that synthetic tube doesn't heal like a native vessel. Sticking it in the same spot over and over again creates a weak point, leading to a high risk of a pseudoaneurysm, basically, the graft wall ballooning out.
Makes sense. And even with a fistula, an AVF, area puncture isn't ideal.
No. If you absolutely have to use a small area because the fistula is short, the recommendation is to spread the sites out as much as possible within that area, trying to mimic the rope ladder idea.
But it's interesting.
What's that?
Despite the strong advice against it, area puncture apparently still happens quite a bit in some places.
A gap between guidelines and practice, perhaps. So let's look at the recommended ones. Rope ladder first.
Okay, rope ladder is about systematic rotation. You move the needle sites up and down the usable length of the axis with each treatment, like climbing ladder rungs. So you need enough ladder to climb on.
Yeah, you need a decent straight segment, at least 5 centimeters for one needle. Ideally, maybe 8 centimeters if you need to put both needles in the same segment.
And that constant moving around is the key benefit.
Exactly. It spreads out the needle trauma, reduces stress on any one spot. That helps prevent complications like aneurysms developing, which is why it's the preferred method for grafts.
Okay, then there's buttonhole. This sounds different.
It is quite different. With buttonhole, you use the exact same spot, the exact same angle for every single needle insertion. Over time, this creates a scar tissue tunnel, or track, down to the vessel.
How do you start that?
You use a sharp needle initially, maybe for about 10, 12, sometimes more insertions, really carefully establishing that track. Once the track is well formed, you switch to using special blunt needles.
Blunt needles, so they just follow the path.
Right, they slide down the established tunnel.
Yeah.
One potential upside is that it could be less painful for the patient once the track is there.
Who might benefit from buttonhole?
It's often considered for patients who self-cannulate, or those with really bad needle phobia or pain issues. Also, sometimes if the fistula is very short, making rope ladder tricky. But there's a big but.
No.
The buttonhole technique, according to some studies in the sources, has been linked to a higher risk of infection compared to rope ladder.
Okay, that's a really important trade-off. So if you are using buttonhole, what's absolutely critical?
Technique has to be meticulous, super strict. That means completely removing the scab over the site before you needle. Use sterile tweezers or picks. No soaking the scab to soften it. That's definite no-no.
What else?
Really good hand washing and cleaning the access site itself, ideally with something like octinodyne wash. For patients who are high risk, some places might consider using mupirocin ointment at the site, but that comes with worries about antibiotic resistance, so you'd need careful screening.
Anything else about buttonhole?
Just be aware that if a patient misses treatments for a while, those tracks can sometimes kind of close up or get harder to use.
Okay, so beyond rope ladder versus buttonhole, there are just general good practices for any needling, right?
Oh, absolutely. Things like picking the right needle size, the gauge. It needs to match the vessel diameter and handle the blood flow rate you need for dialysis.
And the needle length.
Also important. Needs to be right for how deep the vessel is. Too short won't reach, too long might go through.
Where exactly on the axis should you aim to stick?
Ideally, a nice straight part with enough room. And a key rule is stay at least 5 centimeters away from the anastomosis, that surgical connection point. Needling too close there can cause problems.
And the direction of the needles?
Ideally, both go antegrade pointing away from the anastomosis, going with the blood flow.
But sometimes you can't do that.
Right. If needed, the arterial needle, the one pulling blood out, can be placed retrograde pointing towards the anastomosis against the flow. But antegrade for both is generally preferred if possible.
And once the needle's in, any no-nos?
Don't rotate the needle once it's in the vessel. Twisting it can actually damage the vessel lining, kind of like coring an apple.
Makes sense. What about taping, securing the needles?
Standard stuff, really. Gauze over the site, tape securely. The H-taping method is often mentioned, sometimes considered easier for people who self-cannulate to manage. The main goal is preventing accidental movement or dislodgement.
And tourniquets. always use one.
Well, for a fistula and AVF, yes, a tourniquet can help plump up the vein, make it easier to see and feel. But for a graft, an AVG,
Yeah.
they're pretty rigid tubes already. A tourniquet doesn't really do much to distend them, so its benefit is pretty minimal, if any.
Gotcha. Okay, let's talk infection control. We touched on the higher risk with buttonhole, but it's crucial for any needling.
Absolutely paramount. Even though AV access infections are less common than with CVCs, they can still be very serious when they happen.
So what are the key steps? Hand hygiene first.
Always. Good hand washing. The sources mentioned alcohol-based rubs are often seen as more effective and quicker than soap and water in the clinic setting.
Then cleaning the patient's skin.
Yep. Skin disinfection before you stick. Octanodyne wash beforehand for the patient is mentioned as ideal. For the actual prep before the needle, there seems to be a bit of debate noted in the sources.
About what?
Whether 0.5% or 2% chlorhexidine with alcohol is better. And there are some concerns raised about repeated use of the stronger stuff causing skin irritation over time.
Another area where the evidence isn't totally cut and dried.
Exactly. And here's another interesting point from the sources. Some studies apparently suggest that using a full sterile technique for skin prep might not be hugely better at preventing infection than just using a really good, clean technique.
Really?
Yeah, and this is a big but, they also strongly link good patient hygiene overall with less bacteria on the skin, especially less Staph aureus. So the patient's own cleanliness plays a massive role.
That makes sense. What about staff wearing gloves?
Oh, definitely wear gloves. Either sterile or non-sterile are mentioned for the procedure.
And protecting ourselves from needle sticks.
Absolutely essential. Use safety engineered needles. Always. Protects you, protects the patient from potential cross-contamination too. And just to circle back on buttonhole, because of that potentially higher infection risk, all those steps we talked about, meticulous scab removal, the washing, maybe muperus in select cases become even more critical.
Right.
The sources also stress doing a root cause analysis, a deep dive investigation for any bloodstream infection, any bacteremia in a dialysis patient to figure out if anything in the access care process contributed.
So even doing everything right, complications can still happen. We need to be watching out for them constantly.
Continuous monitoring is key, both by you, the professional, and by the patient themselves.
What are the main ones to look for? Infection signs.
Yes, infection,
Yeah.
redness spreading, warmth, tenderness, any pus or oozing. Remember the potential link to buttonhole and risk factors like poor hygiene, being older, recent hospital stays. That Staph aureus link to hygiene is worth repeating.
Aneurysms are another big worry.
Definitely. We know they're linked to sticking the same spot over and over, like with area puncture. Good technique, like rope ladder, helps prevent them. You need to monitor existing ones, measure them periodically.
And the danger is rupture.
Yes, that's the nightmare scenario. If the skin over it gets thin or looks dead, necrotic, the risk of rupture and major bleeding is very real. It's an emergency.
Thrombosis to a clot forming in the access.
Also an emergency. Needs immediate attention to try and save the access. Sometimes the early signs are subtle, maybe just some redness or soreness. Patients should be taught to check for the thrill daily at home. If it disappears, that's a major warning sign for a clot.
And then there's bleeding after dialysis, pain during needling, infiltration.
Right. Bleeding post-needling needs proper pressure, but a major hemorrhage needs immediate help. Pain is a big deal for patients, often underestimated. We mentioned buttonhole might be less painful once established, and infiltration, the needle slipping out or going through the vessel, that's always a risk during insertion.
So combining that daily, feel with maybe those less frequent structured checks seems key for catching things early.
Yeah, it gives you the best shot at spotting problems like stenosis, the narrowing, before it completely shuts down the access.
This really leads into the patient's role. It's not just about us doing things to them.
Absolutely not. The sources really push for involving patients. Their self-care makes a huge difference.
What kind of self-care actions?
Basic but vital stuff. Teaching them to do their own version of see, hear, feel daily on their access. Protecting the access arm, no tight clothes, no blood pressures on that arm, avoiding bumps. Watching their fluid intake between treatments.
Fluid intake, how does that affect the access?
Well, drinking too much leads to large fluid removals during dialysis, which can cause blood pressure drops. Intradialytic hypotension. And surprisingly, the sources link that hypotension to a higher risk of the access failing or clotting off.
Wow, okay. And checking for clots at home daily.
Yes, feeling for that thrill.
What about self-needling? Should we encourage that?
For patients who are willing, able, and have a suitable access, yes. Definitely.
Yeah.
It can be very empowering. If they're using buttonhole, it's best if they establish their own tracks with guidance.
Teaching them must be different from teaching staff.
Oh, for sure. It needs a tailored plan, lots of time, patience, building their confidence, and you need systems to check in on their technique over time, make sure it stays good.
And managing the anxiety around needles. That seems huge.
It really is, often linked to fear of pain. Building a good relationship helps. A calm setting, talking them through it, maybe music, distraction. Some places use visual plans or written steps so the patient knows exactly what to expect.
Good communication is key.
Always.
And just quickly on staff, anyone learning this needs proper training first, right?
Absolutely.
Yeah.
Doesn't matter if you're an RN or a tech learning. You need supervised training. Prove you've got the skill down before you cannulate anyone, especially a brand new fistula. It's not something you just pick up.
There was also a mention of nurses using ultrasound for guiding needling.
Yeah, that's out there as an idea, potentially helpful for difficult accesses. But the sources say it really needs experienced senior RNs with specific, recognized ultrasound training. It's not quite mainstream yet, and more research is needed on its real benefits and how best to train people.
Okay, this all ties into a bigger concept. Shared decision-making, SDM. Making choices with the patient, not just for them.
Exactly. This is a big push in modern healthcare and definitely in dialysis access. Guidelines like KDOQI recommend it. The whole idea is getting the right access in the right patient at the right time for the right reasons.
So how does that work in practice?
Well, the team doctor, nurses, lays out all the options, AVF, AVG, CVC, pros and cons of each for that specific patient. Then, crucially, they ask the patient about their values, their priorities, what matters most to them, give them loads of chances to ask questions.
And the final decision respects both the medical facts and what the patient wants.
That's the goal. It's a conversation, often ongoing, not a one-time lecture.
What kind of things do patients worry about?
All sorts. Needle phobia is huge, fear of pain, obviously, how the access looks, body image, how it will affect their daily life. Can they still work? Swim. And it's pretty striking, the sources say up to 30%, maybe almost a third, of patients who could get an AVF sometimes refuse it.
Why would they do that?
Often it's based on bad past experiences, maybe terrible pain with needling before, bleeding problems, feeling like it took forever, or just hating how it looked. Sometimes they just didn't really understand the information they were given. Or, they might have a different outlook on their life, maybe prioritizing comfort now over long-term access survival.
So preferring a catheter isn't always just about needle fear.
No. Sometimes it's about avoiding perceived hassles, like potential bleeding after dialysis. Interestingly, patient preferences also seem to vary a lot between countries, suggesting culture plays a role too.
It sounds great in theory, but is SDM easy to do in a busy clinic?
No, there are definitely barriers, time constraints, communication challenges. But the shift is important, moving from just telling patients what to do to working with them as a team.
Okay, so let's try to wrap this up. We've covered a lot. The different access types, the critical look, listen, feel assessment.
The rope ladder and buttonhole techniques, the pros and cons, especially around infection risk with buttonhole.
The absolute necessity of good infection control, managing complications, and really bringing the patient into their own care, self-care, self-needling, managing anxiety.
And that bigger picture of shared decision-making.
Right. But here's the really fascinating takeaway for me, something that kind of jumped out from the sources.
What's that?
Despite dialysis being around for decades and needling being such a fundamental skill, there's actually a surprising lack of really strong, high-level evidence for many of the common practices.
Yeah, it's true. A lot of what we do is based on expert opinion, experience, consensus, not always rigorous clinical trials. And you see variations in practice between different units because of that.
Even for things like the best way to prep skin, or sometimes even subtle aspects of needling technique.
It highlights that even in areas we think are settled, the science is still evolving. We're still learning.
So this leaves us with a question, really, for you listening as you move into that RN role or continue developing your skills. How do we keep improving things for our patients? How do we reduce those complications and make access work better when the evidence for some of our most basic skills is still developing?
What questions does this raise for you about your own practice? How do you balance established protocols with critical thinking and new information as it comes out?
It's definitely something to think about, how we continue to learn and refine even the most routine parts of our job.
Being lifelong learners, really.
Thanks for listening to All in All.